As everybody knows, there is a move that had started a number of years ago to take ophthalmology surgery and move it, because it's largely ambulatory, out of hospital operating rooms and into procedure rooms, and in some cases out into the community.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Sarah Ziai and myself, Dr. Guillermo Rocha.
This season, we have two new co-hosts joining us, Dr. Mona Dagger and Dr. Hadi Saheb. They'll be hosting upcoming episodes throughout the season. Season 3 of the EyeCan podcast is brought to you by Bayer Ophthalmology. Thank you for your support. On this episode of EyeCan, we are excited to introduce you to our new president of the Canadian Ophthalmological Society, Dr. Phil Hooper. Dr. Hooper trained in internal medicine and ophthalmology at Western University in London, Ontario. Following this, he did fellowships in Retina and Uveitis at the University of Southern California and Washington University.
He was chair and chief of ophthalmology at Western from 1996 to 2008 and serves as ophthalmology lead for the Ontario Wait Time Program and co-chairs the Ontario Vision Care Task Force. Dr. Hooper became the 70th president of the Canadian Ophthalmological Society in June 2022 and will serve a 2-year term. He has been involved in many COS projects, was editor-in-chief of the Canadian Journal of Ophthalmology from 2008 and 2018, and chaired the Council on Advocacy from 2019 to 2021.
Welcome to the EyeCan podcast, Dr. Hooper.
Thanks very much for having me.
All right, Phil, it's great to have you here and reconnect with you. I think the only thing you haven't done at the COS is precisely the EyeCan podcast, so it's great to have you here. We have a lot of ground to cover in our discussion. So I will try to keep the conversation focused on some of the more important initiatives that you're facing during your presidency. We have identified the need for a national vision health desk in Canada. Can you describe this and where COS is currently in its creation? And also, what are some of the specific deliverables of the project?
Sure, I'm happy to do that. First of all, a vision health desk is basically an office within Health Canada or the Canadian Public Health Agency that will develop a national strategy for eye care and oversee its implementation. There's several integrated facets that will occur. They will identify gaps in vulnerable populations and develop measures to address these gaps in eye care. It may include education, care pathways, facilitation of technology. They'll improve and streamline access to new drugs and technology and identify research priorities and direct funding to them to work with agencies like the CAHR. A side effect of this, which I think is really important for ophthalmology and eye care in general, will be to elevate the profile of vision health at a national and ultimately at a provincial level. The idea has been around for a while. It was supported by the Foundation Fighting Blindness and ourselves, along with the Canadian Association of Optometrists. I think why this is really important this year is that Judy Scrow, who's an MP, has brought forward a private members bill to establish a national strategy for eye care. This will receive second reading November 22nd. And really, in concert with Judy, what we would like to do is to take that concept, marry it to funding, which we're working on by meeting with Health Canada, and we've created a pre-budget submission to the Standing Committee on Finance to basically make this happen. There will be meetings. We've had meetings already with the Public Health Agency of Canada and Health Canada. And this is moving forward to meetings with MP, Finance Committee members as this moves through process. And we should have an answer by March, April, hopefully.
This is amazing, Phil, amazing work. And it really elevates all of eye care really to a different level. Thank you for that.
Phil, can you tell us about some of the other initiatives of importance this year for COS?
I'd like to. I think the first thing I'll start with is the initiative we've called non-hospital surgical centers. As everybody knows, there is a move that had started a number of years ago to take ophthalmology surgery and move it, because it's largely ambulatory, out of hospital operating rooms and into procedure rooms, and in some cases out into the community. The COVID epidemic has really pushed that into fast forward mode. And the concern that has arisen with this is, as care moves from the hospital, can we preserve access for emergency care, special need patients within the hospital? Can we preserve the skill sets of people in the hospital to do this? And if we move out into the community, can we preserve professional autonomy and make sure that we still have the ability to do what's best for patients? And so in working with a number of groups, there was a workshop that carried out in September of last year. And from surveys that have occurred over this past year, non-hospital surgical center advocacy principles have been developed. There are 7 of them. This document's been published, it's been widely circulated, and is available for people to use as these discussions go forward. So hopefully these issues won't be forgotten as there's a rush to deal with care backlogs. The second thing I'd like to talk about is our work with the Health Canada and the federal, what's called the Tier Assessment Committee, which is a group in Health Canada that looks at drug shortages and how to deal with them. As we talk about this, I'd like to acknowledge some really outstanding work that Jamie Taylor has done over a number of years on behalf of the COS, and more recently David Plemmel in this area, and they've really pushed this along. We've developed now a very close working relationship with Health Canada and have given them a much better understanding of sort of the uniqueness of ophthalmic preparations and why shortages are very disruptive to care. Some of the things that have been accomplished through this that I'm very proud of has been the atropine shortage, which occurred probably, I guess, 3 years ago now. Time moves quickly. And through advocacy efforts that we did and working with a number of other groups in Health Canada, we were able to get this elevated to what's called Tier 3. That allows for active importation of drugs and other mechanisms to deal with the critical shortage. We're in another critical shortage right now in terms of potent topical ophthalmic steroids. Very recently, in the last couple of weeks, we've managed to get this elevated to Tier 3 status, and this will hopefully move forward to a solution. And I guess the final thing I'd like to outline is the work that we've done along with the Canadian Uveitis Society and the Canadian Retina Society to develop position statement on the use of ophthalmic intraocular biosimilar drugs. This is of critical importance because biosimilars, the first ones, will be improved through the fall, and that will lead to insurance companies and governments looking to adopt biosimilars as the preferred drugs for use intraocularly. Although these have been tested, there are a number of unknowns, and we've done research and basically outlined specifically what are the unknown factors and why a wholesale move in this direction needs to be done with considerable caution to not put patients at risk. And it's very important, and we've outlined the reasons why, to preserve the ability to move backwards if patients don't do well, and to avoid prescribed therapeutic approaches.
That's great. Thank you for that update. Those are 3 pretty big projects, Phil. One of the things that keep coming up over and over again in the current climate is advocacy. Can you tell us a little bit about how important advocacy efforts are to the organization and some of the current advocacy projects that the COS is working on? Are we trying to support the provincial societies? How are we doing that? I know there's a lot of work to be done. Just give us an idea of how the Canadian Ophthalmological Society is approaching advocacy.
Sure. I guess I'll turn that around and answer it in the beginning with a question, and that is, what do ophthalmologists want? And what I think they want is the ability to practice their profession to the fullest extent of their capabilities and to improve vision-related quality of life for their patients to the best or maximal extent possible. They want to improve the quality of care and the ability to provide high care at the local level, the regional level, nationally and internationally. They want to have access to new technology as it becomes available to help them do this. We want to have our voices heard and respected as discussions are made at all of these levels about how eye care is to be provided. And finally, we want to have a reasonable work-life balance and a fulfilling career. I would state, and I think it's fairly clear, that if we want to do all of these things, we need to be seen and heard as a profession, to be known as the approachable, understandable, and honest purveyors about information regarding all aspects of eye care. And basically, how the organization is trying to do this is to be out in front of the public and government as much as possible, assisting provincial and subspecialty societies in their efforts to do this, so that we are heard and we're out there. We've created resources to assist anyone with this kind of public affairs and advocacy work. It's all on the website. Interestingly, until there's a crisis, there's very little uptake, but it's all there, and it will be very useful to people should they need it. We've worked with the provincial societies, subspecialty societies. I'd mentioned some of the work we've done. We did a lot of work in the last year and a half with Alberta in terms of optometric scope expansion. We've worked with Newfoundland when they had a very restrictive ability for people to access intraocular injections for wet macular degeneration. We worked with them to lobby the government. That was changed. We've helped the Manitoba ophthalmologists develop a very effective provincial society, and we have meetings that we've initiated with the provincial society presidents to understand what are their issues, to develop some consensus nationally, and to see how we as an organization can help them.
Can members still contribute to the advocacy fund, Phil? I know I do, and I do that every time I renew my COS membership. Is that still an option on the website?
It is still an option on the website and can be done at any time. It doesn't need to just be done at the time of membership renewal.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
Good evening. My name is Dr. Robert Kunikoop. I'm a pediatric ophthalmologist, and I work at the Montreal Children's Hospital of McGill University in Montreal. And I follow the EyeCan podcasts.
All right, Phil, recognizing that there are challenges in terms of volume of care that we're providing, how do we focus the conversation on doing care differently, yet at the same time preventing ophthalmology from being relegated to the role of simply technician?
That's tough because, as everybody knows, we're really in a crisis mode in healthcare across the country. There are long waits for access to ophthalmologists to have assessment and medical care, and there's long waits for surgery. Since we're the only eye care providers that are trained to do surgery, there's a real risk that governments and these wait lists will act to channel us into basically doing just the surgical aspects of things and allowing other aspects of our care to devolve to others. And that is a real concern. And I think we have to look at this from a couple of aspects. I think the first of all is the COVID epidemic has allowed us to look at new ways of doing things. And I think that we have, in many respects, had a fairly inefficient mechanism of doing surgery. And one of the things that needs to be examined are things like turnover, the use of bilateral simultaneous cataract surgery, the use of anesthesia, and how the patients move in and out of the operating room space. I think from the standpoint of what we need to do as a profession is, as we talk about these changes and doing more surgically, we need to avoid trivializing the actual surgical care that we deliver. And it's very frustrating to me. I still hear people talking to patients or in the hallways about how simple and straightforward, in quotation marks, the surgery we do is. Anything is simple if it goes well, but it's when it doesn't go well that you need to have skill there in your pocket to avoid what could be a minor issue becoming a crisis. And I think that we need to be very careful to point out that skill level. We also need to avoid trivializing the assessment decision-making that goes into surgery and the post-operative care. We can't devolve these aspects of our care to others, no matter how well-meaning, because they really must remain with us. We need to figure out ways of doing it in a more efficient way. Ultimately, we need more help. That's another thing that we're working with ACUPO to try to make the case across the country that we need more training positions. It's fascinating. If you look at the number of postgraduate training positions in medical disciplines across the country, they have increased significantly over the last couple of decades. If you look at the proportion of these positions that ophthalmology has, we've barely grown. We really haven't even moved a percentage point, and that needs to change given the demographics.
Thank you so much, Phil. These are all incredible points, very, very important points. And I think a lot of things have changed, as you mentioned, with the pandemic. So this leads me to the next question. We're talking about accessibility. We're talking about the volume of care that we provide as ophthalmologists, and also different models of delivering care. There's a lot of discussion with lags and sort of lags in the wait list. So as a national organization, we need to look at expanding the availability of ophthalmology, and many of these aspects could be dealt with in smaller centers. So how do you think we could maintain people in more remote areas where there's possibly more access to operating room time, but we're far from larger centers? So how do we convey that message to the new graduates, for example, so that they can start working and become busy right off the bat?
That's a really good question. I think it's not a unique challenge that ophthalmology has. I think all specialties are looking at how do you make a practice in a smaller center attractive. And it's going to be even more of a challenge, I think, going forward, as there will be a shortage in larger centers as well as smaller centers. And as you've said, I think one of the attractions of smaller center has to do with access to hospital facilities, operating facilities, and to some extent access to all of the other aspects of things, less wait for diagnostics and so on. So there are a lot of pluses. I think things that are being done almost before people enter medicine now are trying to attract people who come from smaller centers into medicine, and that will have an effect going forward. I think supporting people in smaller centers is also important, and we've tried to do that with the PRC and making online interactions, small group sessions available to people regardless of where they are, so that there is that ability. The ability to have remote consultation, I think, has been really helped through COVID, because in a lot of provinces that has gotten actual fee codes, so that there is an incentive, or at least you're not in a negative situation doing this type of remote work. We now have technology, imaging technology, and so on that facilitates this. I think the other thing that can be looked at is the ability, and this is done in other disciplines, and I think we can look at that in ophthalmology, of funding the ability of people to actually go and spend time in smaller centers to provide subspecialty care, basically to provide hands-on help, so patients don't need to leave the local environment, where the ongoing care can be provided by the people that live there. It's a huge challenge, but it's one I think we need to surmount.
Great. Thank you, Phil.
Phil, you're now considered a seasoned ophthalmologist, I guess. You've seen the sector change over the years and you've seen it evolve. What would be your advice for young ophthalmologists who are just getting started, what challenges they might face? I know things have changed a lot. Even for me, I've been in practice for about 10 years and things have changed since I started. But what would be your advice for the new generation of ophthalmologists coming through, and how they can maybe move the needle for the future of ophthalmology?
Indeed. I think it would be worthwhile actually starting a club. I'm one of the members, and there are many others, but I've seen cataract surgery when I trained was intracapsular in the beginning of my residency. By the end of residency, I was trying to learn extracapsular cataract surgery. Then we had to learn how to put lenses within the capsular bag. Then we had to learn phaco, then we had to learn small incision surgery. So I think the first piece of advice is care will continue to evolve. I mean, one of the attractions of ophthalmology is it advances very rapidly, and I think will continue to do so. So you can't sit still. You're going to have to retrain and continue to retrain throughout your career, and you need to figure out how you're going to do that. Hopefully the COS will be there to help with that process. I think you need to maintain autonomy and self-regulation in your practice. There's much more oversight now of practice than there was when I began. And I think that oversight, wait lists management, people looking at quality initiatives, looking in outside centers at throughput, the number of tests you order, how many patients are having special procedures, toric lenses, and so on. These kinds of things can lead to, again, the movement of people from being physicians and patient-directed to being quota-directed and in essence, technicians, very skilled technicians, but nonetheless technicians. And I think that that's something that will ultimately lead to much less satisfaction with practice. And I would suggest that you guard against that. I think you need to maintain a connection with medicine and the patient as a whole. And that again is more difficult as we move largely outside of the hospital setting. And we need to, I think, go the extra mile to be involved with our fellow physicians in the patient journey in order to maintain that connection and to maintain the respect of our colleagues. Those facets of medicine that are least understood are going to be the ones that are going to be more likely, I think, to be marginalized. I think we must continue to be advocates, as I mentioned, on a local level, and we need to engage to avoid trivializing what we do and be part of the decision-making around care. I think in terms of moving the needle, that really comes from some of the things I've already mentioned. I think it's also part, and it doesn't matter what your practice is and where you conduct it, you need to be critically looking at what you're doing, how that stacks up to what everybody else is doing and new developments in the field. What are your outcomes? You will learn, your patients will have a better outcome, and ultimately you may well lead to advancement of the practice of the profession. I look at, this is going way back, but how an ophthalmologist in Santa Monica basically revolutionized the understanding of how to manage retinal tears. And that was all done out of a very busy practice, but it was observing and really moved the needle. And that can still be done. And I think finally, you need to take an interest at a local level, hopefully as well at a regional and a national level, because we cannot sit back and assume others will speak on our behalf. If we do not speak on our own behalf, we will not be heard.
Thank you, Phil. Well, we're closing the episode fairly soon. And as it is our tradition, as we close each episode, we like to ask our guests about some of their non-professional life activities. So we're curious to know what you do in your off time, Phil. I think I have a good idea, but can you tell us how you enjoy your life outside of medicine?
Well, as you know, we've crossed paths, not directly, but indirectly in terms of cycling adventures. So
I know.
Really one of the things I love to do is to do touring cycling. My wife and I have done that both in North America and internationally. I think two highlights that I had was one was cycling with a group from Toronto through cycle pathways up to Ottawa to be part of the 150th Canada Day celebration, and to be able to cycle in and do that was so cool. And I think the other thing was cycling across the Czech Republic, just my wife and I. It was just after I was done being chair, and it was fascinating to see these small communities. Most of them really were very little changed after the fall of the Iron Curtain, and to see how life was occurring then was really cool. I'm sort of an anti, I understand technology, but I'm sort of an anti-technology guy at heart, I guess. My other interest is interesting old vehicles. And what I define as interesting is things that are a little out of the mainstream. I have a car that was the first North American designed front-wheel drive car. They did everything differently. They designed this all with a slide rule, no computers, and most of it works most of the time, and that's cool. I have other ones. I have more modern cars. I have a fascination with the rotary engine, just because, again, small company made something that's totally off the wall work, and it was really cool. So that's another thing that I enjoy. Anyway, I keep busy.
That's excellent. Excellent. Well, thank you to our guest, Dr. Hooper, for joining us. We look forward to bringing you more episodes of the EyeCan podcast. EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
Season 3 of the EyeCan podcast is brought to you by Bayer Ophthalmology. Thank you for your support.
Thank you to the Canadian Ophthalmological Society.
The EyeCan podcast is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.